Hi guys. So I've been studying for some days now, and there are things, some materials I came across that are really opening my eyes to things that we ordinarily do. They are opening my eyes to the other side of things that we had always overlooked. Now let me just give you some additional information over these two common procedures you carry out in clinic, and then some additional things that you fail to observe while carrying them out. Are you aware that while observing the pupillary reflexes, that you're supposed to observe the pupillary reflex both in dim light and in bright light? I mean, in bright room illumination and in dark room illumination. You use your pen torch to observe. And what are you observing under those two different illuminations? Anisocoria. Now, are you aware that by doing that, it will help you to understand whether there is a parasympatomimetic or sympatomimetic lesional supply or stimulation of the pupil, of the pupillary pathway? If in a dim illumination you observe anisocoria, we know that naturally in under dim illumination both pupils should physiologically dilate. Now, if one is dilating and the other one is not dilated, definitely it tells you that the one that is not dilating, the smaller pupil, has a sympatomimetic stimulation problem. It means there is a sympatomimetic problem to the pupil that is not dilating in dim illumination. Now, the reverse will be the case if you are observing the pupil in bright illumination and you observe anisocoria. In bright illumination, it's given that both pupils should constrict. In a situation whereby you observe that one is constricting and the other one is not constricting, you definitely know that the one that is not constricting has a parasympatomimetic stimulation problem. So the parasympathetic innervation to that very pupil that is not constricting, it's under bright illumination, is problematic. Now move on to the pupillary reflex observation proper. I mean direct and consensual. Now, how about your target? What target do you usually give the patients? Now, are you aware that if the visual acuity is less than 618 in the worst seeing eye, that you should not use a distant target. You should use a spot target. Are you aware of that? Are you aware? Then, are you properly doing your pupillary reflex function test properly? Like, you flash the light on one of this pupil, you observe it, you flash the light on that pupil, then you observe the consensual one. You're observing the consensual as you flash the same pupil and remove the light. And then maybe the second time you now observe the direct reflex, observing the pupil you are flashing on. Now you switch to the other eye. As you are flashing the light on it, you want to also observe the consensual reflex on the other eye. And when you are done observing the consensual reflex, now return and then observe direct consensual reflex on that very eye. Now when you are done, you now do the U shape. You want to observe for RAPD, at least 3 seconds delay, so you can give the other pupil, enough time to dilate if it wants to dilate while you shine light directly at it. The U shape, you go underneath the nose, from the pupil underneath the nose, you shine the light, and then you should at least stay away 10 centimeter from the pupil, so you don't have to choke your patients. So these are the little things that you miss out, yeah. And then, how do you do your GAT, Goldman Applanation Tonometry? What do you do? How do you set your probe? And also, You wash your hands. We all know about that one. But tell me the truth. Do you firstly place your patient under the slit lamp to just check that the cornea is intact? Do you do your optic section or your parallel pipe firstly, even before instilling the anesthetic? Do you do that? Then when you've observed that the corneal integrity is okay, because GAT is contraindicated in a compromised cornea, you will only make the condition worse. So when you observe that the corneal integrity is intact, what next should you do? Do you at the anesthetic you install, what's up? Well, what do you know about them? Do you know that there are amides anesthetic and there are esters anesthetic? And then do you know the difference between the both of them? Do you realize that the amides are broken down by the liver, though you instill them in the eye, while the esters, the anesthetic that are ester based, they get broken down right in the eye, locally there? Do you now understand the implication, the pharmacodynamic implication, that this one would take longer time before it gets broken down, while the other one wouldn't? And do you understand the pathophysiology, that for a patient that has liver problem, you are not meant to use the amide class of esters on them? Now let's go on. You instill the fluorescein. Now on the installation of the fluorescein, before you deploy your probe, do you also observe your cornea, your normal staining technique? Quickly observe the cornea to see if there is going to be any fluorescein stain before you deploy your probe. So each and every day, new things, new discoveries that are just inching you closer, that are pushing you closer to becoming the better form of yourself. Cheers, guys.